Thank you for spending your Saturday morning with us. I know that right now things can be a little uncertain and lonely, and everybody's sitting in their isolation, and we all wish we could be together right now, but hopefully these virtual programs will be a way for you to really feel still a part of our community and still feel like you're at least connecting to another human being out there. I know it can be really difficult to not be able to spend time with your loved ones, and we're just really working to ease some of that loneliness associated with isolation. So, just a couple of things before we get started. You can always visit our website. We do still have our patient resources available online for continued support. And although that we are not in our physical office right now, our staff is still working from home. We're always available via text or email. You can call us. We're pretty much working all the time to support you. So you just let us know what you need. In the meantime, we're really working to just provide content in creative ways. So just like today's webinar, we're just going to be doing more things online. I know we can't really be in person right now, but we're hoping that we can still offer content and support virtually. Just a reminder, our first forum newsletter of the year just went out, so you can check your mailbox. You may have received that, and if not, it's also available online under our patient resources publications. And all of our printed materials are always available on our website as well. So we can't fill our physical printed orders right now, but you can still submit your order form online if you'd like, and we will fill them as we are able. Today's webinar is going to be a more formal presentation with an opportunity for questions at the end. So if you take a look at your screen, there is a toolbar at the bottom, and you'll see Q&A. And if you have any questions during the show, you can just go ahead and click on that Q&A button, and you can type in your question to us. And at the end, we will get to all the questions we can as our time allows. And also at the conclusion of the show, we're just going to be offering a couple of polls, a couple of questions that really help us to make sure that these programs are worth your time and you're getting the information that you came here for. So if you would just takes about 30 seconds. They're just 4 quick questions, and if you'll just answer those for us, it's very helpful. So we're going to go ahead and get started. Today's topic is quality of life, a data review and update. So our speakers are taking a look at the quality of life studies that have been done and collected, and they'll be presenting that information to you. Our speakers today, we have 3. We have the Cutaneous Lymphoma Foundation's very own CEO, Susan Thornton. Some of you may recognize her from our live programs. We also have Marianne Tawa, who is one of our board members. She's been on our board since 2011. She is a nurse practitioner at Dana-Farber. She got her master's in primary health nursing and is an adult nurse practitioner. She earned her degree at the University of Pennsylvania in Philadelphia. She currently focuses on clinical care and research of patients with cutaneous T-cell lymphoma. And last but certainly not least, we have Sue McCann. Sue has her Master's of Science in Nursing and is also a registered nurse and is dermatology nurse certified. She is the photophoresis and research coordinator for the Department of Dermatology. So with that, I'm going to turn things over to Susan, and I will see you all at the conclusion of the program. Thanks so much.
Great. Thanks, Hillary. We can just roll to the next slide, please. Thanks, everybody. It's great to be here, and we appreciate you joining us. And for those of you who may be new to the foundation and what we do, just a quick review of our mission, which we recently updated. But it's to eliminate the burden of cutaneous lymphoma by promoting awareness of the disease, providing education like we're doing today, advancing patient care, and fostering research. Next slide. And we also would like to thank our sponsors who make these programs possible by their support, and we really couldn't do this work without them. So it's really great to have them with us and supporting all of our efforts so we can bring these programs to you. Next slide. So today we're going to be doing an overview of all the different the data that's been captured from various surveys and research projects specific to quality of life in cutaneous lymphoma. And I will just mention that Marianne, Sue, and I we're planning to deliver this presentation in March at the Dermatology Nurses Annual Meeting, which of course, like many meetings, got canceled and postponed. So we will be doing an updated version of this, hopefully next year when we can convene again. And our focus, the three of us have been doing specifically cutaneous lymphoma presentations for the dermatology nursing organization for the last 3 years, and trying to raise awareness among the dermatology nurses about cutaneous lymphoma, caring for patients with cutaneous lymphoma, and so forth. So you're actually all seeing this for the first time before anybody else. But we thought this would be of interest to folks. So next slide, please. So I'm going to turn it over to Sue. You're going first, right? Or Marianne? I'm trying to remember. We've practiced this a couple times, and really to talk about, why quality of life in cutaneous lymphoma. Oh no, I'm doing these slides. Never mind. Yes, gosh, forgive me, everybody. But really, why does quality of life matter? And I think for everyone that's here with us today, or if you're listening after this has been recorded, quality of life, particularly in cutaneous lymphoma, is a huge piece of dealing with the disease, living with the disease. It impacts all of us in different ways. For many of us that have the intense itch, we know how impactful that can be on how we live life day to day to day. And it's really important that we bring together the actual experience for those of us living with cutaneous lymphoma and what that feels like every day, and bring and raise that awareness to the healthcare providers, because that all then becomes part of how the disease gets treated, how we find other resources to help us cope. So there's been a variety, and we'll talk a little bit about some of the different studies that have been done over the years and what's going on today in the arena of quality of life specific to cutaneous lymphoma. Again, it's the idea is to really build that full picture, not only just the treatments and the disease itself, but what's the impact on the individual. And again, not only the patient, but we're going to talk about the caregivers and the people that love us that also live with the disease, even if they're not living with it as the patient. Next slide, please. So we thought we would roll this video. Some of you may have seen it. It's on our website. David Lamb was on our board for several years, and I think he brings some humor, but a really good perspective to perhaps what it's like from the patient's perspective. So we're going to roll this video. Hopefully you'll be able to hear it. Give us a second as we get it rolling.
I'm David Lamb. I'm 74 years old. I live in Virginia, right next to Washington, D.C. Have been a CTCL patient for about 10 years now. I went through what I think most patients go through, and that is that the dermatologists were baffled, and they didn't recognize this as CTCL. And the first dermatologist I saw told me that I should get some underpants that didn't have an elastic band. Well, there are no such things. I went on the internet, they don't exist. And then the next dermatologist said that I should change the detergent that I wash my underwear in. And so they were baffled. And the itching by then was so bad that my wife said, you got to find a dermatologist that will listen to you. And I did in Washington, D.C. And he did a biopsy for the first time. And it came back and that I had cancer. When a biopsy was finally taken, the doctor came back to me and said, you've got mycosis fungoides. What a terrible name. To me, it conjured up with some giant middle-aged man coming out of a bog and dripping with seaweed. I mean, I said, it's terrible. Now people don't seem to use that word so much. We seem to use the sort of the umbrella word of CTCL, cutaneous T-cell lymphoma. I've lived with the disease for probably 10 years now. I'm officially in remission, but it's in and out. Periods of itchiness and bad blood cells come back occasionally. So I'm doing fine. I can't complain at all. One thing I think that's really important that I don't see mentioned a lot is attitude. And I really think the attitude you have can do as much for your recovery process as drugs themselves. And I determined that I simply was not going to live as a patient. And I went out and I continued to live my life. I've always been very active. My wife and I continued to socialize. I put together a bicycling trip in Italy for 20 friends. And I was dragging it, but I got through it. And I knew I had a good attitude, and I think it was tremendously important. I never said, why me? My response was, why not me? My whole family had died of cancer, not this kind, not CTL, but cancer. My mother, my father, my brother, my sister. There's no free ride in life, and why the heck shouldn't it be my turn? I've been so healthy, I've never had a broken bone in my life. So I never felt sorry for myself. The Cutaneous Lymphoma Foundation is an advocacy group for those that have the disease that I have. They run patient forums where patients can come and talk to the top specialists in the country in this and ask them one-on-one questions. I really enjoy talking to the patients and seeing how long, where they're at in the disease and what their attitude is. I think we provide a tremendously useful advocacy platform.
All right. Just gotta love David. Okay, next slide, Hill. Thanks. So I'm going to turn it over to Marianne Towle now, who's going to talk a little bit about some of the quality of life surveys that have been done in the past and bring us up to speed. Off to you, Marianne.
Hello, everybody, and good morning. So I'm going to speak a little bit about the history of quality of life in cutaneous T-cell lymphoma, and really the first time that we sort of officially saw questions asked of patients about the quality of life and how the disease and the treatments that are imposed in the course of managing the disease, how they affected that patient. First time it really took place was in 2005. So really, when you think about it, not that long ago. And the pioneer for this survey was Dr. Marie-France Demier. And Marie-France was a dermatologist in Boston at Boston Medical Center, or Boston University. And at that time, she had a cohort of patients with cutaneous T-cell lymphoma in her practice, and really paid a lot of attention to what they were reporting about the disease and said, we really need to understand this better in order to take care of patients, in order to assess response to therapies. We need to know how their quality of life is being impacted by the disease. So she and colleagues there conducted the first cutaneous lymphoma health-related quality of life survey. So once again, it was to look at the impact of disease and the treatment on a patient's lifestyle, their occupation, their social emotional well-being. And the surveys were, at that point in time, the foundation was called the Mycosis Fungoides Foundation. We were not the Cutaneous Lymphoma Foundation, so there we are dating ourselves back in 2005. And the survey was available online. Although my experience, I was practicing then at the Dana-Farber, and many of my patients filled out that survey with pen and paper. Dr. Demier provided us with the surveys, and we handed them out in clinic, and patients really were just so thrilled to be asked these questions. So as a result, we saw that 68% of Cutaneous Lymphoma Foundation members completed that survey. So when we think about surveys in life, that's a huge response rate. Now, the majority of the patients, you'll take this into consideration as you look at some of the results that Demier and her team found, the majority of the patients were early stage. So 94% of them were early stage. They worried, 68% were early stage. 94% of them worried about the seriousness of their disease. 80% worried about dying. So those were two key takeaways. Next slide, please. Other concerns that were derived from this report, from the survey, were 94% worried about the erythema or the redness associated with their disease. 88% worried about pruritus or itch. Functional impact from the disease was also taken into consideration. And I think we'll hear about this a little bit more when Susan reports on the global survey that was conducted a few years ago. But fatigue was a big issue. Sleep disturbance was a big issue. 62% of patients were concerned about their attractiveness. 61% felt financially burdened. And think about this, everybody. In 2005, financially burdened by the disease. Look at how the cost escalation for management of this disease has changed over time, and think about what that statistic might look like today. 85% felt the treatments made the disease more manageable. So that's important as we are seeing drugs go through clinical trials. That's why surveying patients on their quality of life, and we'll talk about some of the tools that are currently used for assessing quality of life, why they're so important, because one needs to know, did that intervention, did that treatment affect your quality of life in a favorable way or a not so favorable way? So Damier and her colleagues published this work. It was a first start. It got CTCL on the roadmap. It got some consideration when it was published in a very important peer-reviewed journal called Cancer. It was helpful because many of these patients were being managed in cancer centers and infusion centers, and people were not really clear, had no true understanding of what it was the patients were experiencing. So it got it out there in the general cancer community. Very important study. Next slide, please. So then Dr. Damier and her colleagues sort of did a deeper dive within their own single site center. So this was published in the Archives of Dermatology also in the same year in 2005. So she took this tool, this survey, the information that was derived for the cancer publication, said, I really want to bring it more into the realm of skin and what was involved in the skin symptoms associated with the cutaneous lymphoma patients. So she conducted the study at a single site. There were 22 patients that were involved in the study. And she used two tools. One is called the FACT-G, and we're going to speak about what that is specifically in the next slide, and Skindex 29. It's important because this was a merger of both general cancer-related symptoms associated with cutaneous lymphoma, but also the skin or dermatology-related concerns for patients with cutaneous T-cell lymphoma. So a very important tool. Many of you in the audience may have been exposed to these tools if you have participated in clinical trials for cutaneous T-cell lymphoma. Surveys may be distributed to you, either the FACT-G or the Skindex 29. You may also sometimes see these surveys in your clinical care in your clinics. Your providers may use these surveys to assess your quality of life. Next slide. So just a little bit about these two tools, just so you can understand it's a beautiful merger of both from the cancer oncology community, but also from the dermatology community. So the FACT-G is a functional assessment of cancer therapy, and it was general. And it was originally designed, the instrument or tool was designed in 1987, I believe, for gastrointestinal cancer. So it's a general cancer tool that you'll see out there with all of the malignancies. The beauty of it is it's self-administered and it's quick. It takes about 5 minutes, and there's 27 questions that sort of scope over 4 domains: physical, social, emotional, family, and functional well-being. So those would take into consideration symptoms of fatigue, symptoms of sleep disturbance, symptoms of pain, of itch, social, emotional, communications, where is the patient's mind at as far as feeling sad, feeling happy, And then functional, are patients able to work, and how well are they doing in the work environment? What is their performance status? And there's a 5-point scale associated with the FACT-G. The Skindex 29, on the other hand, is primarily a dermatology-specific health-related quality of life tool. And there are 29 items, and most of these really connect a skin finding, such as a pigmentary disturbance or a rash, and connect it to an emotional domain. And there's a 100-point scale for that. And once again, that's also self-administered. So either of these tools may be involved in clinical trials, as I mentioned earlier, or they may be involved in sort of clinical care. So Dr. Demier, back in 2005, included both of these tools as she was looking at cutaneous T-cell lymphoma patients. Next slide. So what did Demier and colleagues find? They found that patients with, once again, her earlier study, you remember that I mentioned that it was largely early stage patients that completed her first survey of patients. This single site with 22 patients completing the tool, included all comers, so it was both early and later stage patients. And what she found was that patients with late-stage cutaneous T-cell lymphoma, so stage 2B through stage 4, reported lower or worse FACT-G scores than earlier patients, overall across all domains. So it was a statistically significant finding. Similar results were also found for the Skindex 29, with later stage CTCL had a higher or worse mean scores overall across all scores. So obviously this speaks to the later the stage the patient had, the more impact there was on quality of life. The limitations of the study was obviously, it was a single center, it was primarily a Caucasian population, it was a very small sample size, as I mentioned, 22 patients, and the quality of life was only evaluated at one point in time. And obviously quality of life sort of is dynamic, and it can be quite variable depending upon when you speak to a patient in the course of their illness, in the middle of treatment, after treatment. So obviously that was one of the questions that the group would take on for further study, and I think we'll hear about that later. Next slide. And now on to Sue McCann.
Hi, everybody. It's great to be here with you all in this virtual format. I'm so excited we could do this. So I wanted to talk about a very important global study. We're participating at the University of Pittsburgh Medical Center, along with 47 other worldwide specialty centers in cutaneous lymphomas. And it's across 6 continents. So it's a global effort. And it's called the PROCLIPI study. And that's an acronym that stands for Prospective International Cutaneous Lymphoma Prognostic Index. And just as the title says, investigators are looking for factors that can help to determine prognosis, how well people do, and identify them so that we can manage the disease better. And this is all being done alongside research for quality of life. Next slide. So the important thing about this study is many things I think are important, but one is that the data is all consistent among these 47 centers worldwide. So we're all collecting the same information as best we can, and that includes 7 areas: clinical background like stage, what the skin burden is, how many years they had skin symptoms before they were diagnosed. All patients that enter the study have to be within a 6-month window of diagnosis. So that makes our group homogeneous or the same, even though the disease is different for everyone, but it's all early diagnoses that makes us the same in that aspect. We also look if there's blood involvement, what the pathology shows, what is the genetic component of the tissue. If there are imaging studies done, then those are recorded. What's the treatment history so far? And we're carrying this forward for at least 5 years. So it's going to be, as Marianne said, prospective. It's dynamic. It's over time. So we'll be able to see what kind of treatments are done over time and what effect that has on their response and their prognosis. And in addition, we're collecting at least yearly a quality of life survey. Next slide. So this is a busy slide. I apologize for that. But what I want to show, main point here, is that just from this one study that was launched not that long ago in 2015, look at all the research and new knowledge that's been done. These are journal articles or abstracts that will likely become journal articles. So we are developing a lot of new knowledge. The power in this collaboration is amazing. And I've highlighted here in bold and bigger font the study for quality of life, because that's what we're talking about today, entitled Characteristics Associated with Significantly Worse Quality of Life in Mycosis fungoides Sézary syndrome from the PROCLIPI study. So we'll go into more details on that. Next slide. Two important points about this. It's the first international cutaneous lymphoma health-related quality of life study. That's important because, as I said, there's power in that collaboration. It takes away the single center bias or even single country bias. This is international. And it's the first prospective review of MF and Sézary syndrome patients diagnosed within 6 months. So that, again, makes that group more homogeneous than it's ever been. Next slide. So as Marianne talked about, the Skindex 29 questionnaire that looks at effects on the skin primarily. This questionnaire can be used for other skin diseases like specifically eczema or psoriasis. But it does give them a background, it gives the researchers a background on how the skin is affected by their patient's disease. And we talked about this already. There's 3 subscales: emotions, like is the patient worried, depressed, or ashamed of their skin? What kind of symptoms they're dealing with, like itching, burning, or pain, and how is it impacting function, ability to work, sleeping, or relationships. Next slide. So what was the sample like? So as I said, this launched in 2015. It took a while for centers to get up and involved in this study. I believe we started in sometime in 2017. So these data are from earlier years. So that's right now they have over 1,500 patients in the data set, but this was done early from the questionnaires that were analyzed, 237 of them. And it showed, as it does in the literature now, over the years, we've known that the males predominate in this illness. So that was 143 males to 94 females. That came out to about a 1.6 to 1 male-female ratio, which is consistent with literature. Average age, remember these are newly diagnosed. So we're not only with the quality of life, they're able to correlate with the clinical picture of the patient. So they have the ages. The average age is 60. And the breakdown of patients in classification, there were 211 MF patients and 26 Sézary syndrome patients. And then when we looked at that further, according to staging, there were early stage patients identified at 179 and later stage 58. So of course, the early stage patients outnumbered almost 3 to 1. Of the later stage, that broke down 26 Sézary and 32 advanced stage MF patients. So a much smaller group than the early stage patients. Next slide. So what did we find out from this first study? And there will be more. So this is just beginning to add to the knowledge we have. And indeed, it confirmed that there are emotional, physical, and functional aspects and that impact quality of life. There was a link to the decreased quality of life scores depending upon extent of skin disease, or the MSWAT, if you all know, probably have heard that term, but it's the modified skin weighted assessment tool to determine the burden of skin disease, what stage the skin is in, and if there's any blood involvement. So lower quality of life was seen with higher skin disease burden in later stages, the same as Demir's study, And those patients with Sézary syndrome and widespread erythema or redness also had, across the board, lower quality of life. An interesting finding, though, something that I think added to the new knowledge, is that women overall had a worse quality of life than men. And specifically in the emotional and symptom subscales, they noted decreased quality of life. And some other findings, patients who had an elevated LDH, that's lactate dehydrogenase, which is kind of a non-specific blood test that looks for inflammation. So people that had elevated LDH also had lower quality of life. And additionally, people with hair loss, whether that was on the, alopecia on the head, the scalp, or within lesions, correlated with lower quality of life. Next slide. So in any study, we have to look at the limitations. What could be better about the study? So limiting this, there were less late-stage patients in the sample, so it wasn't really balanced. It did not look at the effects of quality of life on other illnesses, let's say coronary artery disease or severe arthritis. How did that impact quality of life? It didn't look at that. And specific effects of cancer diagnosis and treatments, again, the Skindex doesn't really capture that. What can we conclude from this study? For sure, collaboration is very powerful. It added to our new knowledge base. It strengthened the relationship, what's already known, between the high burden of skin disease and decreased quality of life. Specifically, people with Sézary syndrome had scores in the severe ranges and it affected all subscales of the Skindex questionnaire. And then women generally have more effects on symptoms and emotions. Things like itching, stinging, burning, sensitivity, irritation, and embarrassment or feeling ashamed showed more predominance and effect on quality of life. Next slide. So finally, what's the future here? This is a prospective study that's going on for a while. It's already been recognized that a new questionnaire needs to be developed that looks at the aspect of having a cancer diagnosis and how does that fit in with other aspects of the disease. And there's recognized need. We need to increase awareness of quality of life issues for our patients among healthcare providers so that we can help mitigate that. And it's part of the it needs to be part of the treatment plan. And I think that's my last slide for right now. And Susan, I believe, follows me. Take it away.
Yep. Yeah, great. Thanks, Sue. Okay, so now we're going to take a little different twist on the theme of collecting information about quality of life from the patient perspective. And many of you may have participated in the 2018 Global Patient Survey, which comes out through an umbrella organization that we are a member of, the Lymphoma Coalition, which is a worldwide group of lymphoma patient organizations. So all different lymphomas, there's 101 different lymphomas, I think now. And we send out this patient survey every 2 years to gather from the patient perspective what the impact of living with a lymphoma is on their quality of life. And for the first time in 2018, we had enough patients worldwide answer the survey questions that had cutaneous lymphoma. So we were able to statistically pull that data out and we actually have the report is on our website if you want to go into it in more detail, but we were able to pull our perspectives out from the other lymphomas, which I think is so impactful because while we are part of the blood cancer lymphoma disease community, none of the other lymphomas have a skin component. So we're so unique that we have some things in common with the other lymphomas, but then we have some things in common with people with other skin diseases. So we're this hybrid of disease types. So being able to pull this data out, and again, this is a global survey, so it tries to pull the perspectives from all over the world to the best that we can. So I'm just going to share a couple of the slides and outcomes from this survey. Next slide, please. So I love this slide. One of my colleagues shared this with me, and I had this exact conversation with one of my wonderful physicians way back in the day, Dr. Eric Vonderheide, and we were having a discussion, rather heated discussion about a treatment that he wanted me to be on, and it impacted me emotionally. It didn't work for me from the perspective of how I was able to live my life while being treated for cutaneous lymphoma. And we literally had this discussion, and he said, but it's my job to treat your disease. And I said, and it's my job to live my life, and I think that is so important, because we need, as patients, need to know how these treatments and how things are impacting our life, so that we can continue to live life as best as we can, and be able to have that kind of dialogue with our healthcare providers about choosing the right treatment at the right time for us where we are in our life. And so being able to capture the data from the patient's perspective adds to bringing all the pieces together, so that these things can be taken into advantage. So I'll just share some highlights from the 2018 Global Survey. Next slide, please. So again, we kind of looked through this. This is at the global level. There were over 6,000 people that responded, and we had 203 people, which is amazing and really great, and mostly between 40 and 59 years of age. Obviously, we know this is a disease, generally speaking, that occurs in older adults, so that wasn't very surprising. But we had a relatively equal split between male and female, which I think is important. A slightly skewed female, which, again, I think women in general tend to be more open to answering these kinds of surveys. That's just a general perspective that I have. And it was all done with a third-party research firm, so that the data that gets collected is scientifically analyzed, reported. The survey questions are built in a way that is scientifically appropriate. And that's really important, because now we're able to stand on this data and present it in a number of formats. Next slide, please. So again, as you would probably imagine, it was skewed to the United States, but we did have representation from other countries across the world. And I'll share a little bit about what we know so far from the 2020 survey after we go through a few of these. Next slide, please. So from our perspective, in looking at things from a patient view, this was an interesting slide, was trying to get to, did people receive the information that they felt they needed at the time of their initial diagnosis, either from their clinicians or from other supportive areas? And while most people said they really would like to have received more information at their initial diagnosis. So that gives us some insight into how can we better collaborate, for example, from the cutaneous lymphoma, from us as the foundation, with the healthcare providers worldwide, to make sure that when people are first diagnosed, they receive the information that they need, and then they're also referred to other sources like the Cutaneous Lymphoma Foundation to gain other information when they're newly diagnosed. Next slide, please. And then just where did people source their information? And I think, again, this is very telling, because most people, you'll see the top two are from websites, and 72% from their physicians. And I think anyone that's newly diagnosed, as much as everybody says, don't go to Dr. Google, that's where people will go to see what comes up. And I know for me, well, of course, I was diagnosed in 1991, so that was a different time, pre-internet, and there weren't as many patient organizations like ours. There was no, of course, Cutaneous Lymphoma Foundation. There wasn't even a Lymphoma Research Foundation. And at that point in time, it was just the Leukemia society. It wasn't the Leukemia and Lymphoma Society. So for me, there was really not a lot of other options for support. But today, we have more. And I think this is so important. Again, understanding where patients and people get their information primarily. And I think it goes back to how do we best engage better for people to make sure so that patients can get what they need at the time of their diagnosis. And I think it's interesting that the nurses were only 12%, and that tells me that we have a lot of work to do to educate the nursing community, because at least in my experience, and perhaps from yours as well, and I'm sure Sue and Marianne can speak to this, you know, a lot of times it's the nurses that have that kind of engagement with the patients and their families after a diagnosis, because the physicians are off to the next patient, and it's often the nurses or the nurse practitioners in the practice that are then fielding the questions. So I think we've got some work to do there, but this was so informative, right, to help us determine where people are getting their information and how we can do a better job. Next slide, please. And then how do people feel according to the information that they received? So, and again, this is cutaneous lymphoma specific, and it's most days. And, you know, again, it gives us a sense for, do people feel, how do they feel with regards to the information and the understanding of their disease. And, you know, a lot of people want to overcome their disease, and many people feel like they are in control. But again, it gives us a sense of where we can better support people and how we can bring information to folks in ways that they can assimilate it. And perhaps, I don't know about you, but I think for me, you know, this disease is very complex. It's very hard to understand. It doesn't fit into any standard boxes. It's cancer, but it's skin, and it's hard, I think, to wrap your head around it all. And, you know, a lot of people have early stage and it doesn't progress, and, well, how do I know if my disease isn't going to progress? So, you know, we want to move people over to that in control and confident phase, so that everyone feels empowered to work with their healthcare providers and to be able to maintain the best quality of life that they can. Next slide, please. And then this slide looked at how was their interaction with their physician, and did they share those emotional issues? And it's interesting to say, look at this just graphic. Did you communicate any of your emotional issues to your physician? And, you know, 40% of people said no. And so why is that? And is it time? Is it you don't feel comfortable? Do you not think that it's important? So again, we were able to pull some general information from the 2018 survey, and it gives us a sense of what kinds of issues we may want to drill down into, and how are these emotional issues impacting how an individual is dealing with their disease, and how can we help support that in a better way? And if they're not bringing them up to their physicians or their clinicians, then how can we help maybe bridge that gap and be better able to help support individuals in dealing with these things. Next slide, please. So that's kind of a really high-level synopsis on the global patient survey, and I will share with you that we do the survey every 2 years, so we launched in 2020, and I will say I'm really excited. We had over 400 respondents in cutaneous lymphoma this time, and I know we had respondents from China. We had a higher percentage outside of the U.S., which is really great. The third-party research firm is in the process of analyzing that data now, and we will be, we'll have the report for cutaneous lymphoma maybe sometime in the summer. So when all that data is ready, we'll certainly post it on the website, but I thought we'll also be able to do a webinar like this specific to the results from that survey and let you know what we learned. We asked some different questions as well. And then that data helps us to bring a different, I always think of kind of this research and quality of life as a pie, and there's different pieces of the pie that need to be put together to create the full picture. So what Sue was talking about with regards to the PROCLIPI piece, that's a slice of the pie, and what we learned from the Marie-France-Demier first round of surveys and quality of life, that's a piece of the pie. Now we have the Lymphoma Coalition, that's a different piece of the pie, and the key now is to start to pull those pieces together and understand where they overlap, where the interactions are, where the gaps are, and how do we best collectively serve all of you better. So another component that we're going to talk about is the caregivers, and we thought we'd share a little bit about this because we didn't forget you. So I'm going to turn it over and we'll watch this quick video.
I think for caregivers, my advice would be to really take ownership of that quote that a lot of people say, if one member of the family has cancer, everybody has cancer. Not everybody really believes that, because the person who's sick is the one you notice the most, who's feeling it the most. I'm a very independent person. I don't know that I'm really unusual, though, from other caregivers in that, I feel like, okay, I'm supposed to be the tough one. I'm supposed to be really strong. I'm supposed to be providing because the patient cannot. And so I should be glad for that. But the truth is, you got to know when to take care of yourself. So that would be my biggest message to a caregiver, is know when to take care of yourself, because the patient has to do that. The caregiver has to do that. It's just like they say on the airplane, you're supposed to put your own mask on first before you put it on the child. That's the truth, because there are times when it's really hard and you lose patience, and Dana's not necessarily low maintenance in the first place. So when it gets a big crease like that, then it just means you really got to take care of yourself. I'd say for the family, I think what worked for us really well was we started to set goals. We started to look at things. What could we look forward to that we really want to do? Maybe places we really want to go. I think setting goals and having a positive intention mindset is something that helped both of us to do that. So I'd say that's a really important piece. It has allowed us to do things that we probably never thought would happen for ourselves because of that.
Nancy and I have been together for more than 20 years, and when I was very, very sick at home recovering, she proposed to me and said, we're going to do everything we can to get you healthy and vibrant again, and I would like us to get married. I would like us to go to New York and actually get married.
Thanks. So I'm going to turn it over to Sue McCann at this point, and Hill, can you go to the next slide? Thanks. And to talk about a caregiver burden quality of life study that she conducted, and I think this gives us, again, this is another slice of the pie that plays into the whole. So I'm going to turn it over to Sue.
Thanks, Susan. So as that video and Nancy so eloquently stated and described, there are burdens carried by the caregiver. So at the University of Pittsburgh Medical Center, we decided to look into that. And we did a study entitled Caregiver Burden and Quality of Life Factors Affecting Caregivers Caring for Patients with Cutaneous T-cell Lymphoma. There's our team listed there below. The first four are nurses. This was a nurse-led study, a nurse-driven study, a nurse-designed study, for better or worse. The next two names are statisticians, and then finally our physician mentor, Dr. Akalov, was involved. And we actually got support from the Patrick J. Barnes Foundation to do this study. Next slide. So at the time, you might ask why a caregiver study? And as Nancy said, the family and the caregiver take on the illness of the patient as well. They play a critical role. But the reactions and willingness and abilities of caregivers can differ. Not all are the same. And it's been found in other research that the health of caregivers can change or suffer with things like depression, anxiety, sleep problems, and social isolation. And there are effects on caregivers' roles. For instance, if the caregiver is also a mother or a father, sister, brother, is a nurse or is a social worker, whatever their profession is, their role in life is strained and their personal life is strained. So there are effects that we wanted to look at. However, there's a lack of studies on caregiver quality of life in caring for patients with CTCL. There's tons of studies on caregiver burden in Alzheimer's disease, let's say, or in other cancers, but not this one. And finally, our personal experiences working as a nurse alongside these patients and often alongside patients and their caregivers, you could see the burden not only borne by the patient, but also by that caregiver. Sometimes it was right there on their face, on their sleeve, and sometimes it was carefully controlled beneath the surface. There were many tears and talks outside the hallway away from the patient from caregivers who were just about ready to lose it. So we knew that there were problems experienced by caregivers, and we wanted to look at that. And we also thought there's probably unique factors affecting this caregiver group because, unlike other cancers, they're dealing with all these skin symptoms that can't be hidden from view. Next slide. So that all led us to our fancy hypothesis we came up with, and that is a unique caregiver burden and quality of life for the caregivers of CTCL patients exists. And as such, there may be unidentified and thus unmet caregiver needs. And so we really wanted to delve into that. Next slide. So what were our questions? What did we want to accomplish with the study? And they're listed here for you. I'll read through them. What are the unknown and unmet needs of cutaneous lymphoma caregivers? And are there gaps in services and knowledge? Are we as healthcare providers doing our job? What are the characteristics of this group of caregivers? What does the caregiver group for cutaneous lymphoma patients look like? What are their burdens and quality of life issues specifically? And does that caregiver burden and quality of life differ depending on the stage of the patient's skin burden as the caregiver perceives it to be, which is a little bit of a unique take on this. And are caregivers' needs being met by healthcare providers? So those are all the things we wanted to look at. Next slide. How did we do the study? So we did it at the point of care, whether patients were coming in to the clinic or whether they were coming in for photopheresis or coming in for infusional care or maybe even a research study. So wherever the nurse interacted with the patient is where we would approach a caregiver that attended the visit with the patient. Our goal was to enroll 50 subjects or patient caregivers, but it went on for quite a while and we only could reach 42. So we cut it off at that point. And we think that's because, you know, the bulk of the patients are early stage and often they're very independent and come by themselves. So we didn't see as many caregivers attending the visit. So we asked caregivers when we did see them, would you like to participate in this study? There's 3 questionnaires that we used and they either granted their approval or not. And we had most people did agree to participate. We used 2 questionnaires that are more specific to dealing with overall illness and role and personal strain for the caregiver. One's the Zaret Burden interview, and that looks at personal and role strain. And then one, we chose another one because we wanted to get at that cancer aspect of quality of life. And this is called the Caregiver Quality of Life Cancer Scale. And that looks at social, financial, physical, and emotional aspects. And then to get at that unique burden, we knew we had to develop something else. So we developed a demographic tool. And that had 16 questions in it, and to look at how specific the lymphoma symptoms affect the caregiver. And we wanted to look at just what was our sample, what other illnesses were experienced by the patient, because we postulated that those could impact caregiver stress, and what was causing the stress. Was it the skin disease or was it other illnesses? You know, many of our patients are in an diagnosed at a later time in life, in late 50s and into the 60s, so they may have other comorbidities or other illnesses. And what was the caregiver perception of healthcare provider support and recognition of their burden? So it was a big bill to fill, and next slide we'll look at the results. So on the left, that table, it looks at the characteristics of our sample. We had predominantly females, which would imply then that the patients were likely male. And we had 10 males. But overall, there were more spouses that completed the questionnaires. We had some children, daughters and sons do it, and then significant others. And that could include even good friends that would bring their friends to a visit. So I mentioned we looked at the illnesses that might also be contributing to quality of life in the patient, or from the patient's point of view and the caregiver. And these are a list that we provided to the caregivers to say, hey, what other illnesses might your loved one have that you are also helping with? And most of them were in the realm of mobility, like perhaps arthritis, or being confined to a wheelchair, or let's say coronary artery disease. Those are the two highest. There was also some, if you look further down, there's 7 in mental disorders like depression or anxiety, and 7 with chronic pain. And there were a few others. And then we had another category because we couldn't cover it all. And you can see those listed there. What people pre-texted were some of the other problems their loved one had, like prostate cancer, eczema, glaucoma, hearing loss, sleep apnea, that kind of thing. Okay, next slide. So on the left-hand side of your screen, the demographics, the average age of the caregivers was 61, but our range was big. It was between 29 all the way up to 87. And the 87-year-old was actually a caregiver for her daughter, her adult daughter. Years caring for their loved one, we asked about that, and the average in years was 8.2. And then we also asked, well, you know, how long have they been having skin symptoms that you're aware of? And that kind of matched 8.7 years. Okay, so now on the right-hand side, we wanted to assess, well, what's kind of affecting quality of life? And we asked for the caregiver, and we asked them to assess their loved one's disease. Did they think it was mild, moderate, or severe? So that's the first column on the left of that table. And then we correlated that with the results on their 2 scales, the cancer quality of life and the Zaret burden interview. And basically what this shows, if they thought their patient's or loved one's disease was more mild or moderate, then their caregiver burden was lower. However, if they assessed their loved one's disease as more severe, then their burden was significantly higher. Next slide, please. So on our demographic questionnaire, what did we find that was significant? So again, we compared everything to how the caregiver rated their loved one's illness. So when they rated it as severe, then they were more bothered by scratching and shedding, flaking symptoms than those who rated their loved one's disease as mild and moderate. And that, which makes sense, they probably likely have more of those symptoms. and for caregivers that rated their loved one's illness as moderate or severe. And we kind of collapse those two categories. That in that group, the caregivers were more affected by skin symptoms than those other comorbidities that were in that list. So when the disease becomes more severe, it kind of trumps other things, and they're more affected by the skin symptoms of their loved one. Next slide. So what did we conclude? This was a pilot study. We really had some aspects that could reach significance, but the statisticians pulled us down and said, you have trends, rather than a significance of data that were identified that did support our hypothesis. And those, again, related to moderate and severe disease assessment that correlated with being more bothered by itching and scratching. They did recognize that healthcare providers were supporting them and recognized their burden. And there were increased scores on the burden interview and the cancer quality of life that did correlate with increased severity perceived by the caregiver. Next slide. So what were our limitations for this study? Well, it was small. We had, a diverse group in a small sample size. Diverse meaning, perceptions of mild, moderate, and severe were kind of outweighed. Most fell in the mild category. So again, that is very hard statistically to compare things. So that it led to that wide variation of sample size in the disease groups, severity-wise. And we realized that the demographic tool had some questions. Some caregivers were asking about it. They didn't understand everything. So we need to refine it and do pilot testing. Our recommendations are that we repeat this study with a larger sample size, and we try to control to match, the moderate, mild, moderate, and severe disease groups, so we can do more comparison. And also revise and pilot test our questionnaire, the demographic one, and repeat the study and concentrate more on the moderate and severe disease categories, because that seems to be where the burden is, so we can really tease out more detail about that. Next slide. And I think this is Marianne.
Yes, back to Marianne. I'm going to cover a little bit about one of the important things that's in the CTCL quality of life pipeline. And I'll speak to this in a minute, and that is the Cannabis study that Dr. Mishi Shinohara and her colleagues at the University of Washington conducted and utilized the Cutaneous Lymphoma Foundation and the power of the foundation and the power of the patients within the foundation to gain more interest and knowledge about cannabis use in our patient population. So I'm going to speak to that in a minute, but I was going to go over a little sort of fast facts, general principles about CBD and cannabis. So we sort of have some framework to work with. One of the important things that I just wanted to mention, and I think everybody's probably gotten a good understanding of listening to this talk today, is that there's a lot of interest in quality of life in this disease. And I find, that incredibly rewarding that the current generation of dermatologists, oncologists, radiation oncologists, pathologists, nurses, nurse practitioners, PAs, research assistants, research nurses, everybody kind of taking care of this population of patients, all of us, really care about quality of life. And it's really becoming interwoven in the daily delivery of care. And that when we're assessing response and seeing how a patient's doing, we really haven't hit the mark unless we've improved quality of life. So I think the tools are going to improve, and I think Susan will speak to a little bit of that in the end. And I think the work of the PROCLIPI and the work of the coalition, the Lymphoma Coalition, is really at improving tools so we can ask the right questions and then act on those questions. Next slide. So a little bit about cannabinoids, and there's been a great interest in cannabinoids probably for the past 30 years or so. We've seen a lot in publications. Most of the publications have really been in the lay press. And the big issue with cannabinoids in the medical community, and I think for those of you that have asked questions of your healthcare provider, what about the use of CBD? What about the use of THC in managing my symptoms of pain, skin pain, my symptoms of itch, my sleep disturbance, and such? Those questions are oftentimes not answered by the clinicians, and for a very good reason. And that is because there have not really to date been randomized phase 3 clinical trials. Is not a body of knowledge that we can share on safety of these products. But by and large, they're used out there. And when we look at sort of the statistics here, there's been a lot of exposure and there's a lot of use, so that we need to have a healthy understanding in order to guide our patients. So once again, for the past 30 years, there's been a lot written about, and there's been a lot in use, particularly in neurologic disorders such as seizure disorders, Parkinson's disease, glaucoma, in psychiatric disorders, and anxiety disorders. But once again, there's not been a lot of meaningful regulation of these products. Cannabis, CBD related products, once again, there's not been studies on them, and there's a plethora of them out there. So a little bit about cannabis or marijuana, once again, is now legal for adult recreation and medicinal use in the United States, with 60% of our U.S. population residing within these states. So lots of possible exposure to be had. The downside is that nurses and other healthcare providers are not really well equipped to answer a lot of these questions. And I must, about this topic, and I must say in my practice, I have learned a lot from my patients. I've learned a lot from caregivers about the use of cannabinoids, whether it be CBD alone or THC containing products. I've learned about sort of how it works for patients by them sharing their stories. So another sort of fast fact here is that the endocannabinoid system, we all have it. It's in our central regulatory system throughout our body. It's a large receptor system, and it helps to facilitate homeostasis, or sort of an even kale. So as humans, we produce our own cannabinoids on demand. Next slide. So, what's the difference between CBD and THC? These are sort of the entry-level questions patients get when they hopefully get answered when they enter, whether it be a recreational or a medicinal shop, to sort of inquire and perhaps purchase their products. They need to understand this. So exogenous, meaning outside of the body, phytocannabinoids, or THC, is a psychoactive compound, meaning it kind of has effects within our brain. And that's the what we understand with THC, the response that one gets with sort of feeling chilled out, or for some users, it may be the feeling of being a heightened sense of awareness, or being, for some, even the downside of feeling anxious. So that works on the CB1 receptors in our brain. That's why we feel those effects. Cannabidiol, or CBD, works mostly on our immune system, creating that homeostasis. And there's also anti-inflammatory responses that can occur through these receptors. So where do we find CB1 and CB2 receptors? Well, when we think about skin diseases, there are a lot of CB1 and CB2 receptors in our skin, which is really important. But we also see these receptors in other sites, such as in cutaneous nerves. So that's why I think some of the work that we're going to hear about with Dr. Mishi Shinohara and her group made the question be asked, with these products, are these products being used by our patients for managing skin symptoms? Cannabinoids have anti-proliferative, meaning reducing the effects of cancer cells in vivo. So in the test tube, some studies are being performed. THC has shown impact on migration, angiogenesis, and apoptosis, which is destruction of cancer cells. Next slide. So when one goes into, whether it be a medicinal or a recreational shop, there's a big tutorial that takes place. And many patients have shared with me, particularly those that are have been either CBD or cannabis or marijuana naive, they don't understand the difference between these products. So they'll get sort of a general introduction about oftentimes these two strains, which is indica and sativa. Those are the two broad types that you tend to see with various THC and varying CBD levels. So what needs to be considered is with THC is the percentage versus CBD. So the higher the percentage of THC containing products, the greater, quote, the high a patient would get. Those that are higher in CBD have less of that, quote, psychoactive effect. So sativas are a taller plant, and the indicas are a shorter broadleaf plant. And they're adjusted by a variety of methods, and I'll show you that on the next slide. But, you know, they're not without potential side effects, and those could be dysphoria. For some patients, it's not a heightened sense of awareness and a feeling good. It could be a negative impact. It can cause anxiety for some, panic disorders for some, impaired memory, fatigue, dizziness. For some patients, an increased heart rate and dry mouth can occur. Next slide. So patients will say, well, I'm not so interested in going into one of these shops. Is there a prescription cannabinoid that I might be able to get exposed to or get a prescription for? And there is one prescription, which is a synthetic THC. It's called Marinol. In cancer settings, oftentimes a prescription cannabinoid may be recommended for patients who have poor appetite relating to their cancer therapy. That tends to be the greatest utilization of this product with mixed results. And once again, the clinicians would sort of titrate or adjust the dose depending on whether or not the patient had ever had a prior exposure to a cannabinoid. The science of cannabis for cancer treatment and palliation is emerging, and we'll take a look at that in a minute when we look at a study that related directly to the cutaneous lymphoma community. And the products come in a variety of forms. The one thing about the topical CBD products is that CBD products, because skin is a great receptor for CBD, it has great bioavailability. And I think that's why a lot of work is being done to look at the effects of CBD on skin, because it's a great receptor, because we have lots of CBD receptors in our skin. So a lot of these products you'll see sold as salves and lotions and creams. But once again, none of them have gone through clinical trials. None of them are FDA regulated. And of course, the edibles, particularly with the combined THC to CBD products, you'll see here the gummy bears and cookies and tinctures and the like. Next slide. So that brings us to a cannabis study that was conducted with our own cutaneous lymphoma population through with the assistance of the Cutaneous Lymphoma Foundation. And the work of Dr. Mishi Shunahara, once again, and her colleagues at the University of Washington. And they surveyed our patients, and some of you in the audience might have participated in the survey, and thank you if you did. And the question was on their use of cannabis as an anti-itch remedy. So, you know, bear in mind, we talked about the skin as having a lot of CB1 receptors. So, well, would this work for itch? So the question was, why survey cutaneous lymphoma patients? Why do we want to know whether or not they've used cannabis? Well, it's because many of our patients suffer from itch, refractory, recalcitrant, difficult to treat itch. And they've tried and failed many, many standard therapies. And those standard therapies could be anything from moisturizers, topical corticosteroids, antihistamines, neurokinin inhibitors, drugs like gabapentin, anti-opioid agents, et cetera. So a whole host of agents, phototherapy, et cetera, have been used to manage itch, and for many unsuccessfully. There was limited evidence there that cannabis may have anti-itch properties. So despite legalization in many states, the available data doesn't really come from our scientific journals. It comes from social media and friends. So Shunahara and colleagues really wanted to know what specifically the cutaneous lymphoma patient population could tell us about itch and cannabis. And they discovered that patients needed to share and were able to share beyond the symptom of itch. So there was a 75% response rate from the study, which once again, I think is superb. It was largely early stage patients that responded, similar to the earliest studies in cutaneous T-cell lymphoma and quality of life with Marie-France Demier. It was early stage patients that responded. Most patients had addressed skin itch with either moisturizers or topical steroids as their prior therapies. Next slide. And that would be standard for early stage patients. So what did Shinohara and colleagues find? Approximately 50% of patients reported exposure to cannabis. That's a fairly significant number. 40% were currently still using the product. Now, bear in mind that this is much higher than the general population, where it's about 13%. 50% of patients use cannabis to reduce anxiety, pain, and stress. So not necessarily itch. And I would probably, venture to guess that when future studies are done, and we'll hear about those hopefully as she continues her work with colleagues, but for many patients, I think sleep would be added to the mix. 25% of patients used to treat itch solely. And with that, they patients reported a reduced itch and improved symptoms. Patients expressed a strong interest in learning more about cannabis and its use in lymphoma, and patients expressed an interest in wanting to discuss this with their care providers, with their cutaneous lymphoma providers. So that really, that struck me when I looked at the response to her survey, to their survey, was that patients wanted to have this discussion. They wanted to have this on the treatment ladder for symptom management, and that providers needed to be there to participate in those discussions. So obviously, this work suggests that we need further evaluation and obviously additional research on this topic, and that is where her next phase will be taking us. Next slide is Susan.
Yeah. So, and I think we can go to the next slide. I think we have a list here. Yeah. So what's in the pipeline? So as Marianne said, I think more work, and hopefully Dr. Shinohara and her team and perhaps some other clinicians will do more with regards to cannabis. I think it's an interesting, a really fascinating area. As I mentioned, the global patient survey, we had over 400 people participate, and they're crunching the numbers. So as soon as we have something to report on that and to share, we'll probably do a webinar like this and share the data, and then we'll also be sharing the results and the output with the clinical community and the research community as well. Let's see, quality of life survey update. We're hoping to, there's a project kind of underway, some talk anyway amongst the clinicians of pulling together a specific survey instrument for quality of life for cutaneous lymphoma. As you heard throughout all the different pieces, there's not one survey instrument that kind of meets the full needs of quality of life in cutaneous lymphoma. So there's interest in trying to develop that instrument, which I think would be really beneficial, so that we would have an instrument that combines the cancer pieces and the skin pieces and all of those pieces together. So we're not always having to do Skindex and some of these others. So that is, well, we'll see how that goes, but there's a lot of interest in doing that. And there have been several other quality of life surveys in specific centers where they're gathering some data. So again, trying to come up with something where we can pull together that data. And the patient-reported outcome registries, that's a project that's ongoing and really just kicking off. That's through the U.S. Cutaneous Lymphoma Consortium. So that's through the professional organization that has been in development for quite a long time, and that has a quality of life component, but also a whole pulling together data based on treatments within each institution. So if your physicians are asking you to answer some quality of life in relationship to the registry that the U.S. Cutaneous Lymphoma Consortium is conducting. Please, if you're interested, that would be great. And again, it's another slice of this pie in collecting information primarily geared towards how are treatments working and over the course of time. And then with all of the clinical trials, there's really quite a big push, quite frankly, from the FDA in including quality of life components in the clinical trial process. Mary Ann mentioned that as well. And that is, that's an evolving science. There's way more interest in pulling the quality of life components into the whole clinical trial process. And some of these other pieces and the data that we're gathering can truly help inform the clinical trial process and what kinds of treatments are needed, particularly in our disease state, and why it's important. Why is it important to have another topical treatment in cutaneous lymphoma? And we need to be able to share with the FDA and the regulators why it's important to continue to research and have products in clinical trials, and how does that all work to the benefit of all of us that are living with this disease and managing it and treating it, and also hopefully inspiring and incentivizing the biopharma companies and the research companies to continue to conduct and do work in developing new treatments in cutaneous lymphoma. So all these, again, just all these pieces all play together, and it's an emerging component that is getting a lot of focus, and it's very exciting, I think, to see where we are in a small rare disease, but we really have been able to pull a lot of pieces and parts together. And this just kind of gives you a synopsis of what's been happening and where things are. There's a lot of work to do, obviously, and we need all of your help to try to do that. But hopefully this was a beneficial overview of quality of life and data and what projects are ongoing and what projects have been done, and how we're hoping to use the information. Sue or Mary Ann, anything else that you might want to share with regards to what's in the pipeline, if I forgot anything?
I would say for clinical trials, there is now focus when there's a comparative agent, say they're studying standard of care agent with a new agent, they are doing quality of life that looks at what was the effect of treatment on quality of life. So I think that's going to be probably part of clinical trials going forward.
Good point. Good point. Yeah. Yeah, so it's important, even to be able to, if we have data on some of those older treatment modalities and what was the impact on quality of life, so that you can compare a new agent and what the difference is. And that is becoming important. Right.
Yeah, and I would say that, moving forward for a lot of patients when they're sort of evaluating or analyzing a potential treatment, that having the quality of life data that was associated with that clinical trial is really helpful in decision making on what you may or may not be signing up for. So I think it's really going to be important for the next generation of drugs that come up along our way, et cetera.
Right. Great. Thanks. I think next slide. I think we're up to questions. Yeah.
Or
yes.
Survey.
Questions. Question time.
So,
all right. Well, we have a couple questions here, and I know we're a little bit over our time frame, but let's go ahead and get to these, and then we'll wrap up. So some interesting questions, as always. From Les. Does quality of life vary by where on the body the disease is most prevalent? Any thoughts on that, Sue or Mary Ann? I have my perspective, but
I would venture to guess what the answer potentially could be, that the exposed areas, but I don't know if any of that work, such as the face, but I don't know if any of that work has ever been done. Sue, you may know.
Right. Yes, I'm unaware of any studies that have specifically looked at where on the body the disease is present. But I agree with your kind of gut feeling that it would definitely affect quality of life. And I think that's a very good point, something that we need to keep in mind going forward. It may be what perhaps in the PROCLIPI study, when women were found to have more worsened quality of life based upon their symptoms and feeling embarrassed or ashamed. If it's visible skin disease, then yes, I would venture to say that that's some relationship. But I don't think it's formally been studied.
Yeah, and I think these are the kinds of questions that as we are able to drill down, now that some of these baseline studies have been done or we're starting to collect some of this data, the trends to what you've done, Sue, on the caregiver side, looking at these trends and then being able to drill down and say, being able to come up with some ideas of where the impact may be. I also think about, in very sensitive areas of the body, that may also play a role, when you're talking about, intimate relationships and things like that, and that can certainly be an issue as well that people, I'm guessing, would not be super open about to talk about, but is definitely would have an impact. So thank you for that, and hopefully we'll have a chance to do some of those questions. And the second and last question we've got is, have any studies been done in the area of different blood types, but more specific in the RH factor, negative or positive? And I'm guessing that is, does blood type have an impact on the disease, on the perhaps prognosis or intensity? I don't know of any off the top of my head. I don't know if either of you have.
I'm not seeing anything.
Yeah. And I think, again, especially with the bigger, broader studies that we're doing, like through PROCLIPI or through the U.S. Cutaneous Lymphoma Consortium registries, being able to look at all of those different kinds of things to see if there are trends that might point to additional research that might need to be done. So is there a higher prevalence of diabetes as a comorbidity or something, and what's the impact on disease severity or on treatment and things like that? There's so much work that we can do. So I think that's a great question. I wish we don't have good answers, but hopefully we'll be able to track some of those down. Let's see, and let's see some more. Support is an important component of quality of life. Agree. The Cutaneous Lymphoma Foundation has provided vital resources for this person. Oh, we're so glad. Human and material, so thank you. What is the process to arrange the regional peer support groups that you have in certain locations? Oh, I guess I'll be answering that question. So we're piloting some online opportunities and options for the current networking groups that are in place, with hopefully the long-term goal, but don't hold us to this, of once we figure out how that all works and how we do that we may be able to roll that technology out to a broader group. And then, one of our challenges and with the local networking groups has been, finding people who are willing and able to take the lead in that, in their geography, and then finding a location to host. So with maybe, one of the silver linings of this pandemic challenge is looking at online alternatives and perhaps being able to have opportunities to use technology to do a similar thing, which then makes it a little bit easier to meet. So thank you for that, and I'm really glad that you brought that up, and know that we're looking at all of those things, and hopefully we'll be able to do more to bring people together, because I think, what we've heard as well from people, and while we can't meet now in person, once we are able to, and it's safe for everybody to get together, I hope we'll be able to continue to have our in-person programs, because I think they're so valuable for people to actually be able to meet and connect in person. I know I certainly miss it. The online is great, but it just doesn't beat being able to be in person. So we're hoping to do that. Okay. Oh, good question from Pamela. How about studies related to the cause of the disease?
Well, I
either
think
of you want to comment?
Yeah, I think that they're kind of ongoing. That involves a lot of different kinds of research on a, not only a cellular level, but even on geographic and, epidemiology. And there have been some studies reported on that. I don't believe that they have been widely verified as, okay, now we know what the cause is. They're still considered theoretical in terms of genetics or environmental exposures, things like that.
Right.
What do you think, Marianne?
Yeah, I would agree. And then also just, once again, I think if you just, for example, the research newsletter that was submitted, we just recently received on all of our doorsteps from the Cutaneous Lymphoma Foundation, the research update. We just look at, right now somebody is probably trying to break back into their lab to do their basic research on this disease, which a lot of it has been sort of put on temporary hold given the pandemic, but there's basic labs everywhere in the United States and obviously well beyond, looking at pathogenesis in this disease. And I'm hoping that will obviously someday be able to allow us to use the cure word.
Right. Yeah, we still have a lot of work to do. I know from my experience in listening to the science and the researchers, it continues to baffle people. There's not what happens in this disease is so complex. There's not, we've got some ideas and we've got some markers and some things that all play a role, but there's so many things that impact something else, and trying to tease that all apart to figure out which are more important than the other, or how do they all work together? Is it a pathway? Is it a protein on the cell? Like, what's broken or what's overworking and what's underworking? It's like it's a puzzle. And then I think, to your point, you toss on top that most lymphomas happen in an older population as our immune system ages, so that plays a role. And then does exposure and so forth play a role? Probably is all a piece of the pie. And again, similar to doing the quality of life components, pulling all of those things together, getting good data that can actually be analyzed and looking at maybe trends, and then doing the deeper dive research into determining what might actually be happening. We've got a long way to go. I know our research advisory council that we convened a couple of years ago, and we are building our research support funding mechanisms to be able to support some of this kind of research. I mean, they basically said, look, we're a good 10 years behind as far as what we know about the disease itself, how it manifests, how it works, what's wrong, how it manifests in the body, and then the rest of the more mainstream B-cell lymphomas. So there's a lot of research that needs to get done as well. So anyway, with that, I think we're going to finish up and let everybody get back to their Saturday. And I know I really want to thank everybody that was able to join us today. And if this was a valuable event, we really would like to know. I think Hillary's going to run a quick poll here before we finish up. And if, we want to be able to do more of these kinds of programs, and if you find these things valuable, please, if you're able, I know this is challenging for everyone, but if you are able to support the foundation, we greatly appreciate it, because we need your help to be able to continue to function and to operate and to invest in technology and be able to do the things we really would love to do. So if you're able, please, I know just a little pitch for Giving Tuesday Now, which is coming up on Tuesday, and you know, it's for all the nonprofits out there as a push to support all of us that you know, are also impacted by the pandemic, and trying to do our best to keep our doors open. So thanks for spending the time. Thank you to Marianne and Sue. Hopefully this was of interest, and we'll bring more of this kind of content and data to you as we go along. And I'm going to toss it back over to Hillary to take us home from here.
Yep, just wanted to mirror what Susan said. Thank you for joining us. And our poll will wrap up here in about 15 seconds. So if you would just take a second, give us your feedback. It's really valuable to us to make sure we're serving you in the way that we should be. So with that, thank you, Marianne. Thank you, Sue and Susan, for spending your Saturday morning with us. And we hope that you will join us at a future webinar. So thanks, everybody. We will see you all again.
Thanks, everybody. And thanks to Hillary and to Holly on the team who provided the back end, that you guys don't always see the people behind the scenes that make us on the front side look really good. So thanks, everybody, and have a really great weekend. I hope you stay safe and stay well. Let us know how we can help and support you. Feel free to reach out anytime. So have a wonderful, wonderful rest of your Saturday.
Bye, everybody. Thank you so much.